You're listening to
CRST,
the podcast
from Bryn Mawr Communications.
Welcome to CRST, the podcast. I'm John Hovanesian. I'm an ophthalmologist in practice at Harvard Eye Associates in Laguna Hills, California. And today we have a really interesting and very timely topic, office-based surgery. And I'm joined by two people who know more about this than anybody I know, Mark Lobanoff and Dagny Zhu. Let me introduce them. Mark, you're at Ovo LASIK and Lens in Minneapolis. Thanks for joining us.
Thanks so much, John, for having me here. Very excited about the topic.
It's a great topic. And one of my other favorite people, except when I'm competing against her in the ASCRS Foundation event when Team Barbie beat my Team Marvels, Dagny Zhu from Hyperspeed LASIK and Envision Eye Centers in Rowland Heights, California. Dagny, nice to see you.
Yeah, thanks. Nice seeing you, John. And thank you for acknowledging our win, but we did do it together for a common cause. So nice to see you. Nice to be here.
Yep, that's right. I Care for the Underprivileged was the real winner of that evening, and we all did great, and we all looked great. Today's topic is really an interesting one. We're going to talk about office-based surgery. Both of you have done this in your own practices, and I'm excited to hear your perspectives. My own perspective on this is I work in an ambulatory surgery center, a more traditional setting where most surgery in the US is done. And yet, when we built our new office, a large facility, we did it with office-based surgery in mind, knowing this is in the future. How far in the future, I don't know, but I hope to get more comfortable today with some of those concepts with advice and guidance from smart folks like you who've done it. Let's start, Dagny, if you don't mind sharing how you first considered doing and why you first considered doing office-based surgery in the first place.
Yeah, John, I love how forward thinking you are and already implementing steps to adopt office-based surgery for your own practice, because when I graduated from fellowship and I took over a large cataract refractive practice, I was lucky to find one that was similarly forward thinking. And so they actually already had office-based surgery built in, maybe for 10 or even 15 years or so. So they were very forward thinking. And having transitioned from traditional training where we are all used to operating in a hospital-based setting and going to office-based oral sedation, no IV sedation, no anesthesiologist, it was definitely frightening for me. And for a small moment in that transition, I wanted to go back. I was like, why are we doing this? But to be honest, having done it now for the past 7 years, having done probably over 3,000 cases now in office, I could never imagine going back to traditional, ASC or hospital-based surgery. And there are just so many benefits to the patient and to the surgeon as well when it comes to autonomy and having control over how we want surgery to run. So I definitely think that OBS is the future. And I'm happy to, continue giving talks on this topic and reassuring our colleagues that it is something that they can take on. If I did it as a new grad, honestly, anyone can do it. And I do think that we're headed in the right direction with office-based surgery.
Great. And I want to come back to that concept of you being really still getting your surgical sea legs, if you will, kind of learning to be confident as a surgeon and doing it in a completely unfamiliar setting. But Mark, tell us in your perspective, why did you first start to do an office-based surgery? Why did you contemplate it in the first place?
Well, I'd seen the evolution of cataract surgery throughout my career. I'm a little older than Dagny, so when I first began, we did a lot of our cases in the hospital. And then for my large group, I formed a multi-specialty ASC. I served as medical director on that ASC for 16 years. So I was very comfortable and familiar with ASCs, both setting them up and operating in them. But when I was breaking away to form my new clinic, Ovo LASIK and Lens, I really wanted it to be a premier center. We really wanted to be a center of excellence for refractive surgery, for cataract surgery, and we felt there was a big growing market for refractive lens exchange.
Yeah.
So in looking at that, we wanted our location to have a great clinic, a great LASIK center, and an office-based surgery suite where we would have full control over the schedule of surgery. Even though I was medical director for the ASC, even though I was the one that designed it and built it, towards the end, I struggled to get block time in my own ASC.
Yeah.
I didn't want that to happen. And so the beauty of OBS, full control over scheduling, full control over speed of case turnover, and many other aspects are in your control.
When you started, Mark, did you have patients who, thought twice about this? Did you have anybody who kind of knew the alternative and was hesitant or questioned it?
I wouldn't say patience, but I was. So I had I had cashed in all sorts of investments. I had built this clinic, built the OBS, and the very first day, I'll never forget it. I was about to start my first case, and I had this mini panic attack. I thought, I've always operated with IV sedation. I'm about to do a full day with oral based sedation, and I didn't know quite how it was going to go. To my extreme pleasure, it's better. Patients do better on oral sedation. And I really feel that's been the case for the patients we bring to our OBS. Doesn't mean there's not still a role for ASCs, and we still bring patients, some of our patients to an ASC. But really, the beauty is that oral sedation worked fantastic. So the nice thing is we can show patients in our clinic, here's where you're going to have your surgery. They can actually see it. And it's a very impressive space. And I think that gives patients some confidence in what we're doing.
Dagny, tell us your perspective on that. You use oral sedation as well in your office space facility, and what was that like for you, especially as an early career surgeon? And Mark, you mentioned that you're a little bit older than Dagny. I'm a little bit older than Dag. Hell, I've got socks that are older than Dagny. Dagny, what was that like for you early in your career?
So it was definitely challenging because, like you mentioned, I was dealing with so many new things, right, as a new grad. And surprisingly, it honestly made things easier than I thought it would be. So I had mentioned that in the beginning, we actually wanted to try something new because I did partner with a large group, which was also new to OBS. This was the only center that they acquired which had OBS. And so they were used to ASC IV sedation. So they weren't even sure whether this was going to work out. So literally for the first 1 or 2 months, we had the center revert back to IV sedation with an anesthesiologist in-house. And so we did things a little differently than how this center historically did things. And I have to tell you that the patients, they did not like it. They came to our practice because we have a great reputation, similar to Mark's practice, getting the best experience, best technology, sort of a LASIK-like experience, and having to fast, before surgery, and sometimes having to cancel their cases because of that, having to get poked, with an IV. It made it very non-LASIK-like. And then the post-op nausea and vomiting, we got calls for. And so it just wasn't providing the experience that our practice was known for, delivering. And really, I felt like these patients, deserve better. And so very quickly, we actually went back to the way things were. And that's when I saw for the first time the difference. These patients with oral sedation, it's a very slow release pill. You can use, the MKO melt, which is midazolam, ketamine, ondansetron. But to be honest, the majority of young, healthy patients, or actually older cataract patients who are already a little bit kind of calm at baseline, they need something even lighter. Sometimes it's midazolam or Valium, similar things that we use for LASIK. And it's a very slow release. And because of that, they're not waking up and jerking during surgery. They are in a twilight zone and just comfortable from the beginning. It's a very slow release over 20 to 30 minutes. And so they don't get a lot of the adverse effects that you often see with IV sedation. And if you look at the evidence, comparing oral sedation, IV sedation, almost in every aspect, in terms of, relaxation, adverse events, they're equal. But where the difference lies is actually oral sedation always comes out on top when it comes to patient satisfaction and undesired patient movement. There's less undesired patient movement with oral sedation. So in many ways, it's actually safer. And we saw that. And so we went straight back to oral sedation right away. And I know it's something that's scary for a lot of surgeons, but I think that, if you give it a try, I think this is a great way to transition, is that if you're already doing, cases in your ASC, maybe go a day without, giving IV sedation. You can keep the IV there in case a patient needs rescue, but just try oral sedation for your patients. And I think you'll really see and appreciate the difference.
So let's unpack safety a little bit, because I have some colleagues who have, discussed with me candidly their feelings about it and feel like office-based surgery cannot possibly be as safe as being in a full-fledged operating room. Tell me your perspective on that, Mark, and then Dagny.
So I understand the concern, but I think some of it comes from the misconception of what we're really talking about. A lot of the naysayers have never actually stepped foot in an office-based surgery suite. And the OR is identical to the OR that you would see in an ASC. The same sterilization, the same instruments, everything is packaged and prepped the same way. And so part of it is the unknown. We are creatures of habit, especially in ophthalmology. We do a lot of cataract surgeries. We do a lot of routine things. We like doing them the same way. And when something moves us out of that comfort zone, we really look at it askew a little bit. But what I will say is the safety data has really been proven. If you look at the information from IOR, we've done over 350,000 successful surgeries in OBS. And as you look at the complication rates, they are lower across the board in OBS centers than they are in ASCs. Now, caveat to that statistic. Yes, a lot of these patients who are in OBS are a little bit younger, a little bit healthier, so there is a little skew to that. And my patients who are a little more medically fragile, I'll bring them to an ASC. But all things considered, I firmly believe it is as safe to perform a surgery in an OBS than in an ASC.
Dagny?
Yeah, if you look at the actual rates of endophthalmitis, TAS, things that we're really scared of, it's actually surprising that's lower in an OBS setting. And I think part of that also has to do with, the fact that we have equal accreditation across both facilities, but maybe the OBS surgeon is paying even a little bit more attention on the matters of safety. And the fact that we get to employ our own scrub technician who's trained within ophthalmology, I think helps a lot when we have those scary cases where something goes wrong and you need the retractor. You need to make sure the technician knows what they're doing, right? And that's something that you don't always have in a multi-specialty ASC. Is having control over your staff and someone who's actually knowledgeable about ophthalmology. I think that's another added layer that's of safety that OBS provides. And I also want to point out the misconception that Mark, you alluded to earlier, that we're only doing the easiest cases in OBS, the young, healthy patients. I think that's absolutely not true in every setting. So I serve a very large working class demographic, and a lot of these patients, they don't believe in seeing the doctor until the very, very end. And so I will routinely be doing a brunescent, sometimes monocular patient in an OBS setting. And definitely don't recommend starting there, but it's definitely somewhere that you can build yourself up to once you develop that confidence. And again, I do feel that confidence doing it in an OBS setting because I have all the equipment that I need, similar to an ASC. I have staff that I think is even more trustworthy. And so I'm confident bringing these patients in. I've only had one patient that I refused to do in my ASC, and that was a very non-ophthalmic eye. I wanted IV mannitol, but to be honest, every other patient I've been able to do in my OBS setting.
All right, let's take a quick break. And when we get back, we're going to talk about how we actually would implement the nuts and bolts of starting to have an OBS in our practices.
This episode is brought to you by IOR Partners, the pioneer of office-based surgery. The demand for cataract surgery is skyrocketing, but OR access is limited. It's time for an innovative shift in surgical care. IOR Partners is leading the shift towards office-based surgery. Our turnkey solution provides the support you need to perform safe and effective surgery while you control the entire process in your customized IOR surgical suite. Learn more at iorpartners.com/CRST. That's iorpartners.com/CRST.
Welcome back to our discussion on office-based surgery. So I'd like to talk about some nuts and bolts, but one of those nuts and bolts for me is efficiency. And Dagny, tell us what sort of changes in efficiency you noted when you started working in this OBS environment.
Yeah, so we've talked a little bit about how it's beneficial for the patient experience and also surgeon autonomy, but one area that I didn't expect to see such a benefit was actually with my staff. I feel like OBS actually empowers your staff and increases retention because in order to function in my practice, we're training our staff to cover multiple roles in the clinic and in the OBS. And I feel that my staff feel empowered by that. I'm able to put my scrub technician, as the lead scrub technician on OBS days, but at the same time, she's in clinic working up patients on the floor. And same thing, my laser technician who's doing my femto cataracts, he's on the floor working up patients, discharging patients. And so having this ability to be trained in multiple skills, I think is empowering for staff, but also great for staff retention, especially in this climate where it's getting so hard to hire new staff. I think having the OBS setting within your practice allows you to utilize your staff in ways you never thought possible and also helps to save on your overhead in that way. So I definitely see that enjoyment in my staff. They like taking on additional responsibilities, and it certainly helps our practice as well when it comes to efficiency. And there aren't, empty days where I feel like the staff is wasted or I have their hours cut. If I'm not doing surgery one day, all that staff is moving over on the clinic side. And similarly, I feel like I can always be there for my patients. I'm not far away at a discrete location doing surgeries where I can't see a consult who maybe wants to meet me and I otherwise would lose that opportunity. I'm literally jumping back and forth some days from my OBS into clinic to be able to see patients on both sides. And so I definitely think it adds to the efficiency that I'm able to provide for my patients and for my practice.
And I'll bet patients love seeing a familiar face when they come for surgery instead of going to an unfamiliar place with unfamiliar faces. That must be a real positive for some folks.
Absolutely. I actually just had one patient recently. She was terrified of cataract surgery, put off surgery for 4 to 5 years, and she was doing her own research, looking up any surgeon that did office-based surgery because she knew she was terrified of IV needles and anesthesiologists. And she found our little location. And so she finally had surgery, was very happy. But before she committed, she's like, can I get a tour of your office? Like, I'm free this morning, or get a tour of your office-based suite. I'm free this morning. And of course, having OBS and not working at ASC, we were very accommodating of her schedule. We're like, sure, come on in. And we gave her a tour that same morning that she requested it. We had her meet her staff, the same person who would be discharging her the day of surgery, who would be taking care of her the day of surgery. And so she formed that relationship, far in advance, which is something that I think would be a lot more difficult to do if we operated in an ASC traditional setting.
Sure. Yeah. Mark, we were talking about efficiency. Tell us your perspective on that.
So we had an interesting situation that came up recently, and there's a company that will come in and they'll bring a surgical tech in. And if you needed additional equipment, they can bring it in. And so they were very interested in our OBS. This is the first time they had brought a surgical tech to operate in an OBS. They were so impressed. They said, we want to come back and do a time efficiency study. They had done time efficiency studies at 81 ASCs across the country. And we had the fastest turnover time of any center out of those 81.
Wow.
Now, what helps with that? Well, the pre-op area is very close to the OR. So there's shorter time just walking, something as mundane as that. You're not searching for an IV. You're not hunting for a hard to find IV in someone who's been dehydrated overnight because they're MPO.
Yeah.
Patients have a little more flexibility in scheduling. They don't have to schedule a pre-operative history and physical. So we really found there's so much more efficiency in the OBS than even an ASC. ASC is certainly more efficient than a hospital. This is really the next stage in evolution.
So finally, let's talk about the people element of this. And what I mean, there are a lot of reasons a practice would want to consider opening an office-based facility. Either maybe you're opening a new location that's further from where you already are and you need to be able to do surgery closer for patients, or you're expanding, or perhaps you're doing more, like most of us, more refractive lens exchanges, and you want to keep that cost down, or ICLs, or other cosmetic procedures. It makes eminently sense to have a simpler facility to do that. But both doctors and affiliated staff who might come along with this can be hesitant. What is the conversation like with colleagues when you're trying to get them comfortable with the idea of oral sedation and a simpler process for patients? Dagny, you want to start?
I think one major hesitation or barrier still goes back to not having the anesthesiologist or CRNA present in the room and you feeling like you as a surgeon have to monitor everything. I think that's a big fear of a lot of surgeons. And the fact of the matter is that because we're using oral sedation, just the inherent nature of what we're using is so much less risky health-wise compared to IV anesthesia. So you honestly don't need an anesthesiologist in the room when you're administering this very low risk oral sedative. And actually, you get into more trouble when you oversedate patients. And that's one thing that I learned very early on is that patients who are oversedated, they become paranoid, they sit up during surgery. That is the worst thing that you can do. Under sedation and using lighter sedation is always better. And verbal anesthesia is heavily underutilized. And I think surgeons don't realize this, but a large portion of my cataract patients I actually do with just oral anesthesia. And it is safer for the patient because sometimes they do have comorbidities, they're a little bit more frail. To be able to do this surgery and walk them through just verbally without having to put anything in their bodies, especially with this opioid crisis going on, I think is overall safer for a lot of these patients. And because of that, there is less fear, there should be less fear associated with the surgeon, being able to handle that in an office-based setting. And we check vitals on all our patients preoperatively, but beyond that, there's really minimal risk, health risk that I would expect during a relatively straightforward short cataract case.
Mark, how do you talk to colleagues about what this change is going to be like? How do you get them comfortable with it?
I think it's a big enough change that they actually have to see it for themselves. And again, I think there's this misconception that there's some dingy room that's been recommissioned into an OR. That's absolutely not true. It's really a beautiful state-of-the-art OR. And so seeing that for themselves, and they say, that's the same instrument tray I use. You're draping the same way. They can see the patients get off the bed in their own clothes and walk out of the OR on their own power. It's pretty impressive. And so I really think seeing is believing. And I think a lot of the misconceptions come from folks that just aren't picturing what we're really doing.
And let's talk about reimbursement. This is a nuts and bolts item that matters a lot because we don't have a traditional facility fee, but how does that work?
I'll jump in first here. So you get the same surgeon fee that you would if you operated at a hospital or ASC. So your surgeon fee is not going to change. Now, in terms of the quote facility fee, right now they use certain codes that are approved by the local Medicare group. They've usually a company has helped you negotiate that. So both the Medicare regional group and the company that's handling your billing understand how to communicate with each other. They know what codes we're using. The codes sound strange to cataract surgeons. One of the codes is neurolysis, the cutting of a nerve. Well, we are doing neurolysis. We're cutting through corneal nerves. People say, well, that sounds really funny to me, but it's an agreed upon term between Medicare and the billing company. They know what that means. They know what they're doing. What I find is that our quote facility fee is less than an ASC, but at my ASC, we had a management company that had 51% ownership. 51% of the profits immediately was off the table going to this management company. You don't have that here. So in reality, even though we get a little less on the facility side, I tend to see more revenue than I did when I was part of this ASC.
Perfect. Dagny?
I can't comment too much on this because our practice, we've opted out of insurance. We're completely cash, but I can definitely say that that's one area where you can start is with RLE, ICLs. And because the overhead is just so much lower with an OBS, a large part of that because you're not using an anesthesiologist, you're going to be able to get a lot more patients than you otherwise would for those refractive procedures. So a lot of patients were coming to us because we were able to offer lower ICL prices, RLE prices compared to some of our competitors. We're still operating ASC. And I think the overhead cost in terms of initial investment to build up, an OBS versus an ASC, that's where the other large difference is. I think a lot of younger surgeons coming out wanting to do their own thing, it's going to be pretty difficult these days to build your own ASC at a reasonable cost compared to maybe a few years ago. And so I think OBS is a great place to start where you can do it really in a feasible way financially and still attain some of that autonomy that you get as an ASC owner.
Perfect. And Mark, as you were starting this transition, there must have been things that we've already heard about some of them that were positive about the efficiency, about the human element, but there must have been stuff that didn't go as well as you expected. Tell us about that and what you did about it. And Dagny, then same question to you. Mark?
We had a really good launch. It's kind of hard for me to find areas where we struggled. I think part of it was giving it time to see what the reimbursements would be. You hear you're going to be reimbursed. It's another thing to actually see the money come in and make sure that you're meeting your bills. And so that was a little nerve-wracking at first. The second thing is training our staff. As Dagny said, there's a lot of advantages. Our staff really feels like they have ownership of this center. They take pride in it. Just like me, I don't want to be in clinic 5 days a week. I don't want to be in surgery 5 days a week. Neither does the staff. They like a little variety. But we had to find staff members that were interested in learning, that could be trained, That took a little time. There was a little bit of a shift. Some staff members were better at sterile processing, others were better at a surgical technician. So finding the right spot for each individual within our organization, that was a little challenging at first.
I can understand. And Dagny, same question to you.
So I alluded to this earlier that my biggest mistake with transitioning to OBS was overdoing it with sedation. I was under the misconception that we're not doing IV anesthesia anymore. These patients are going to be so nervous. They're going to be in pain. And so I was giving everyone MKO melts in the beginning. And honestly, I learned quickly that less is more, especially the older the patient, the more you can back off on sedation. And patients who are actually a little bit more heavier set, perhaps risk factors for sleep apnea, I tend to ask every patient now, do you snore? Or they're ask their wives, does your husband snore? And those patients, I really back off on the oral sedation. Sometimes I cut it in half. Sometimes I give them nothing at all because they tend to fall asleep during surgery with nothing at all. And so I've just learned tips and tricks over the years on how to properly sedate these patients, even with oral titration. And a lot of times, nothing at all works best.
And John, one question I sometimes get is surgeons say, well, what if the patient starts to get more agitated halfway through the case? I'm used to telling the anesthesiologist, give more IV. You can give the MKO melt. It begins working within 2 minutes. You see the maximal effects at 20. So we have this rescue procedure where if the patient does get a little agitated, and it's rare, you can give them another MKO melt. Just talk to them for about a minute and a half, 2 minutes. It takes effect and you continue going on your way.
You just slip it to them under the drape. That's what we do.
Yes,
Slip
yes.
a little in the corner of the mouth. So you can still titrate with oral sedation. And so you learn these little tricks along the way.
Absolutely.
The biggest takeaway I have on office-based surgery is how enthusiastic the doctors are who have implemented it. And that has to be the result of just seeing all these positives despite doubts that frankly everybody has when they start. And so this has just been really enlightening for me, and I hope for our audience as well. That's the end of our time, and I want to thank you both, Dagny Zhu and Mark Lobanoff, for joining us on this discussion on CRST, the podcast. I'm John Hovanesian. Thanks for listening.